A 57-year-old woman was diagnosed with stage 2A, ER+, PR+, HER2-negative breast cancer. She received adjuvant chemotherapy, completing it 10 months ago, and has been amenorrheic since chemotherapy. Prior to chemotherapy, she had regular menses. Her oncologist wants to start an AI, but needs to confirm her menopausal status. Amenorrhea for 10 months following chemotherapy in a 57-year-old woman is sufficient by itself to confirm postmenopausal status for the purpose of initiating AI therapy. Answer: false. For women under 60 experiencing chemotherapy-induced amenorrhea for greater than 12 months and serial estradiol and FSH levels in the postmenopausal range are required to confirm menopause, and amenorrhea alone, especially for less than 12 months, is unreliable. Aromatase inhibitors are equally effective in suppressing estrogen whether ovarian sumption is present or absent. Answer: false. Aromatase inhibitors work by blocking peripheral conversion of androgens to estrogens and are inactive in women with intact ovarian function. Ovarian suppression or ablation is necessary if AIs are used in premenopausal women. If menopausal status cannot be definitively confirmed, initiating tamoxifen would be an inappropriate choice for this patient. Answer: false. Tamoxifen is effective in both premenopausal and postmenopausal women. If menopausal status is uncertain or confirmed premenopausal, tamoxifen is a standard endocrine therapy option or an AI combined with ovarian function suppression. According to NCCN criteria, is age greater than 60 years old considered a sufficient criterion for defining menopause in women with breast cancer? Answer: yes. The NCCN definition of menopause includes age greater than 60 years old as one of the criteria. Can menopausal status be reliably determined in a woman currently receiving ovarian function suppression therapy, example goserelin? Answer: no. Menopausal status cannot be determined in individuals actively receiving ovarian function suppression, as the therapy itself alters hormone levels. Is prior bilateral oophorectomy sufficient to define a woman as postmenopausal for treatment decisions? Answer: yes. Prior bilateral oophorectomy is one of the explicit criteria for defining menopause according to NCCN guidelines. A 68-year-old obese, BMI 36 kilograms per meter square, postmenopausal woman is 2 years into adjuvant exemestane for stage 2A ER-positive, PR-positive, HER2-negative breast cancer. She reports increasing fatigue, difficulty concentrating, and admits to occasionally missing doses over the past few months because she feels unwell. Her last bone density scan showed osteopenia. Obesity, BMI greater than 35 kilograms per meter square, has been consistently shown to have no impact on breast cancer recurrence risk in postmenopausal women receiving adjuvant endocrine therapy. Answer: false. Some data, such as a post-hoc analysis of the ATAC trial, suggest that a higher BMI, greater than 35 kilograms per meter square, is associated with a greater risk for recurrence despite endocrine therapy, although not all studies confirm this association consistently across all populations. Fatigue and cognitive difficulties, forgetfulness, are not recognized potential side effects of aromatase inhibitor therapy. Answer: false. Studies have reported higher rates of cognitive problems and identified fatigue and forgetfulness as predictors of AI discontinuation, indicating they are recognized potential side effects. Missing occasional doses of exemestane is unlikely to have any clinically significant impact on treatment efficacy or outcomes. Answer: false. While data specifically linking adherence levels to breast cancer-specific mortality are limited, studies suggest low adherence, less than 80%, increases all-cause mortality risk, and one study linked biochemical non-adherence to tamoxifen with shorter distant DFS. Therefore, maintaining adherence is stressed as important for maximizing treatment impact. If switching to an alternative AI, anastrozole or letrozole, a reasonable strategy if exemestane is poorly tolerated due to fatigue or cognitive symptoms? Answer:
Yes. Individual patients may tolerate one AI better than another, and switching to an alternative AI is a reasonable approach if the initial one is poorly tolerated and other management strategies fail. If this patient permanently discontinued exemestane 6 months ago due to side effects, would restarting adjuvant endocrine therapy, either the same or a different agent, potentially offer any benefit? Answer: yes. Data from the MA.17 trial, restarting letrozole after placebo, and a Swedish registry study show that restarting adjuvant therapy after discontinuation was associated with improved DFS. Does the development of osteopenia while on exemestane necessitate immediate cessation of AI therapy? Answer: no. AI-induced bone loss leading to osteopenia is a known side effect. Management typically involves monitoring, lifestyle modifications, calcium and vitamin D supplementation, and potentially bone-modifying agents rather than immediate AI cessation unless severe osteoporosis or fractures occur refractory to management.
What topic should we bite next? Comment below. Subscribe and hit the bell for instant updates. Explore our channel for more. Find more info at HemOncBytes.com. Stay current, stay curious.